Vegeta, this is just to do a sound check. Are you able to hear me? How are you?
Hi, good morning. Yes, you sound great.
Okay, good. Thank you. And let me just try to share if it comes out true. You tell me if you're able to see and in presentation mode. Are you
I
able?
Yes,
Okay, good. Thank you.
of course. Hello, everybody. Good morning. Good afternoon. Hi, Dr. Phiri.
Hello, thank you.
Thank you for being here.
You're welcome. Thank you.
My guess is people will trickle in a little bit more slowly than usual because it's just turned 7 a.m. here. And the students have all been on a little break past their first exams. So I think they're all coming back from that.
Thank you. We will just wait. Whenever you're ready, then we will
Okay.
have a go.
Yeah, we should, I think we'll start in maybe 2 minutes. I will read 2 to 3 minutes. I'll read your bio and we'll get started. And Dr. Phiri, I also wanted to just take a quick minute to introduce you. You've interacted with Vegeta over the years, but Elizabeth is a new member of our team, Elizabeth Contreras, who has her camera on, and she's helping us with our tech needs today. So hopefully everything will go smoothly.
Thank you. I think because I was the first to come in the room and she came in, so I was like, "Hello, we had not met." So my apologies, Elizabeth, because then I said hello to Vegeta after you had already entered in. My apologies.
Oh, no worries at all. It's great to meet you.
Thank you. Good to meet you too. Thank you. Looking forward to continue the partnership.
Thank you. Me too.
Good morning, Dr. Phiri. I hope you're doing well.
I am actually well, thank you, Vijeta. And well, yes, it's good morning for you. You know, it's
Oh,
almost
sorry,
close
good
to good evening.
afternoon. Yes, good evening to
Yeah,
you.
good evening. Thank you. Good evening. Thank you.
I'm
Uh,
sorry, it's Monday morning, so my brain is not all here yet. So good
uh,
afternoon, good evening to you.
thank you. I know for you the day is still a puppy, but here it has grown up already.
Absolutely.
Thank you.
Okay, so I'm learning that the link is not working for some people who are trying to get in. So I want to make sure we get them in. We're expecting about 35 people today, Dr. Fury. So let me just see if I can resend
Really?
that link.
What did you do? Really? Because when I saw the list over here, I'm like, we are already overpopulated. We are over 30. What's going on?
Yeah, there was a lot of interest. And I was actually surprised because the students have options of which partner conversations to attend, and getting up early is not super easy. But yes, this is a very, very popular topic. So I just want to make sure that everybody has the correct link, and then we will get started. So give me just one more minute. All right, I'm going to go ahead and start reading Dr. Fury's bio, and then we can get started. A few more people are trickling in, but that's okay. So we have the pleasure of introducing today Dr. Sam Phiri, who is a program director at Partners in Hope, Malawi, providing strategic leadership to a large PEPFAR USAID-supported HIV care and treatment program, managing over 207,000 people living with HIV on antiretroviral therapy. Before PAH Partners in Hope, Dr. Phiri was executive director of Lighthouse Trust in Malawi for over 20 years, managing a PEPFAR CDC care and treatment program with over 170,000 people living with HIV on antiretroviral therapy. He's an accomplished implementation scientist with a large body of published work in areas of prevention of mother-to-child transmission, of tuberculosis, HIV, and also NCD integration. His interest is HIV treatment and care, operational research in infectious diseases, particularly sexually transmitted infections, HIV and AIDS, and tuberculosis. Dr. Phiri received a master's degree in sexually transmitted infections and HIV from University of London, London School of Hygiene and Tropical Medicine, and University College London, and then was awarded a PhD in clinical epidemiology from the University of London, also the London School of Hygiene and Tropical Medicine. Dr. Phiri is a professor in the Department of Medicine at the University of North Carolina School of Medicine at Chapel Hill, the Department of Global Health at the University of Washington in Seattle, and he's a professor at Kamuzu University of Health Sciences in Lilongwe, Malawi. We are really, really lucky to have this talk from Dr. Phiri today, and I will let him go ahead and get us going.
So thank you for that introduction. Just confirm that you are able to see the slide deck and in the presentation mode. Thank you. At this point in time, we'll just proceed to make sure that we go through the presentation. We are talking about the HIV national response using the Malawi experience. And in this case, the outline of the presentation is that we'll just look at HIV and AIDS, the global update in brief. Then we look at the HIV situation in Malawi. We look at an example of programming of HIV prevention and treatment and care in Malawi using the Partners in Hope program where I work. And then we look at, while we are within the HIV programming, knowing that people live longer now, looking at integration of non-communicable diseases in routine HIV care. So this is just calling out the 2024 Global AIDS Update Report, which is published by the UNAIDS, and this was laid out in July. And what is being mentioned is about the agency of now, while we talk about AIDS at a crossroads, whether we are continuing to increase on infections or we are reducing over that component. So this is just to look at, so close to 40,000 people are living with HIV globally. And if you look at this, you see that 52% of those are in the Eastern and Southern Africa, so in Sub-Saharan Africa. So Sub-Saharan Africa takes the largest share of the number of people living with HIV globally. But as you know, this is also the area where the resources are limited. And therefore, it is really something else to think about. While actually, when we look at where you are living, basically, which is in that case, the component of, you know, that we are seeing those which the Caribbean, which is available, Europe and Central Asia, Latin America, and we look at all these, the largest component is within the Sub-Saharan Africa. This slide is just to show you in terms of just for you to know that when you look at new infections, a period over in the early 90s to actually 2023, you see that the new infections have declined and they are currently around 1.5 million or so. And then when you look at AIDS-related deaths, you see that this has also declined, and these are gone below 700,000, about 640,000 or so. So this is a sign of the response that the globally has been made in the introduction of antiretroviral drugs, which has reduced the new HIV infections, at the same time reducing the AIDS-related deaths. But however, when you look at the targets here, where we are supposed to be here 2025, which is just next year, you can see that if we go that way, we require a miracle to swift to go down or to swift to go down. We will miss this target, but I think we are still on the trajectory of declining. When we look at the number of people receiving antiretroviral drugs, the good news is that globally, the number has gone also exponentially, over 30 million people. In this case, over 30 million people are currently on antiretroviral drugs. So this is translating to treatment as prevention. That's why we are seeing a decline on the new infections, but also good health care because of the test and treat, which was started in 2016, where everyone who is HIV positive, regardless of their clinical stage, CD4 count, or any condition, they would be started on antiretroviral drugs. You might have heard, some of you who have been interested in global programming, the global AIDS. So this is to look at the number of people who are living with HIV out of the close to 40 million people. How many of those know their HIV status? And out of those who know their HIV status, how many of those have been started on long-term antiretroviral drugs, the ARVs? And out of those who have been studied on long-term antiretroviral drugs, how many of those have actually viral suppression, where their viral load is actually significantly lower than it can be not be dictated? In this case, in 2025, the target is that there should be 95% of those who are living with HIV should know, and out of those, 95% should be started on treatment, and out of those, 95% should be virus suppressed. For 2020, the target was 90%. So for the 2025 95% target, as of the end of 2023, 86% actually were actually aware of the HIV status, while 89% were actually started on antiretroviral drugs, and 93% were virally suppressed. So we are moving closer to reaching the 95%, and we expect that we should be able to be closer to that. We'll see how it comes out, but we are optimistic that we should be able to get, especially for the viral suppression, which is already above 90. Now, this is just to look at how is it looking amongst children between 0 to 14%. How is it looking for women 15 years and above? And how is it looking for men 15 years and above? Excuse me. So for children 0 to 14 years, it is actually 66% knowing their status, 57% actually started on treatment, and 48% virus suppressed. So as you can see, this is really way low, below the 86, 89, and 93. However, when we look at women, these are 91, 83, and 78. This is really good because we have 91% knowing status, above 90 already, and then we have 83 and 78. Men, these ones actually are lower, and I don't know how many are in the attending this course. We know about the health-seeking behavior of men, and this is being translated that it is slow and delayed globally. At least I know from Malawi too, that men actually tend to go to the health facility later than women, because the women, when the child is sick, when they are sick, when a husband is sick, or a spouse is sick, or when a neighbor is sick, they would all go to the facility and have an opportunity for testing to be done. But for men, as we can see, is 83, 72, and 67. And this is a sign that there's a lot of work on men, and there's a lot of work on children in order to make sure that we achieve the good progress on the program. And this finally is, as you know, if someone is HIV positive, they have a high risk of getting TB. So as we were looking at the years from 1990 to 2023, here is just from 2010 to 2022. These are the notification of new and relapsed TB episodes. At the same time, also new cases that come. So the blue here is actually the number of people who have been notified. So this is basically about 500,000 globally. And then as you can see over here, then you're looking at the number of people with HIV and TB receiving antiretroviral therapy. So in this case, we are just trying to make sure that those who are receiving antiretroviral drugs, they are less likely to have actually TB. So there's a decline on the TB new infections because of that. Now, let me just check as I've moved with global. Now I'll be moving into the Malawi HIV burden. So let me just have a flag out that we are doing well in terms of seeing the slides, at the same time also looking at the slides that are still looking well. Let me just have a sign to me that we are okay at this point before we transition to Malawi.
I think it's been good, Dr. Phiri.
Thank you. So now then, Malawi HIV burden and response. Here, we are talking about sustaining gains and accelerating progress towards epidemic control. So this is a Malawi National Strategic Plan for HIV and AIDS 2020-2025. And just to let you know that Malawi, as of 2024, a population of about close to 22 million, and therefore the growth has been really significant, with a projected increase of 29% as we reach 2030. So this is a potential challenge for maintaining epidemic control because of the high population, but the program is targeting. The vision, mission, and goals and objectives of the strategic plan, focusing on make sure that we have a healthy and prosperous nation free for HIV and AIDS, and then providing high quality HIV prevention, treatment, care, and support services for all Malawians affected by HIV and AIDS. The main goal towards 2030 is to contribute towards ending AIDS as a public health threat. There are 5 objectives: reducing new infections from 34,000 in 2020 to 11,000 in 2025. And then reducing HIV and AIDS-related morbidity and mortality, and reaching 95 treatment targets, and to improve the quality of HIV services. And finally, making sure that we're building the resilient health and social welfare systems in Malawi. So this is an estimate which is used as what the UNAIDS, they call it Spectrum as a platform, and also the Naomi as a platform. So this is just, so it's a busy slide, but don't worry about it. What I just wanted to emphasize to you is that when you look at all the population of over 20 million in Malawi, you would estimate that about 1 million people would be living with HIV, with about 15,000 new infections, with an incidence of 0.08. AIDS deaths, about 11,000. So in this case, this is, we're looking at that is general above, but now the population, all, these are the ones 15 years above, who are sexually active. So when you look at that, the HIV prevalence is around 8%, and we expect new infections about 13,000. That was, it is estimated that would have 9,500 deaths. So just to mention that the incidence amongst the targeted populations, for example, pregnant women, female sex workers, men of sex with men, transgender, people who inject drugs, those ones actually, the general prevalence is about 0.13%. It is higher, slightly higher compared to 0.12. So these are just the numbers of the new infections, and they are higher in terms of those amongst the female sex workers, but also we know that amongst pregnant women is over that. Otherwise, this is what you would have seen amongst the children 0 to 14 years. You'd have about 1,900 with a 0.02, and the deaths about 1.6%. So it's a busy slide, but you study it when you get the slide deck. So this is just to demonstrate what I said, that there's been a decline from 2010 of number of new HIV infections by 75% up to 2020. We expect that we should go to reduce by 90% in 2030. These are new infections. So the key is the reduction by 75% by 2020. And then so the change in new HIV infections since 2010 was 79%. So 12,000 in 2020 were like a new infections compared to the 13,000 that we expected. When you look at the number of deaths, we'll see that we targeted 75 and 90 for 2030 and 2030. And the good news is that there was a 70% and we have 11,000 new infections in 2023, which is really moving towards a good direction from what we planned. If we want to translate, when you look at this data, these are number of AIDS-related deaths versus number of deaths averted. So if we continued without antiretroviral drugs, actually this would have been the number of deaths that would have been. So would have gone as far as close to 80,000. But because of the antiretroviral drugs, there's been this decline that I showed before. So these are the number of deaths that have been averted because of the antiretroviral drugs, about 804,000 deaths between 2002 and 2030 that have been averted. Excellent work for the program. This is just to look at the ART coverage, the actual proportion of people who are on antiretroviral drugs, and facilities who were providing some antiretroviral drugs in 2004 were only 17. But we have now over 800 facilities providing that. And the coverage of drugs, whereby the number of people who are eligible to be started on antiretroviral drugs because of their HIV positive, and then as a denominator, the numerator being the number of people who are currently on antiretroviral drugs. So that's the coverage that we're talking about. And if you look at that, you see that amongst males, amongst males, it's about 89% in 2023, females 93%, and children 72%. So doing pretty much well amongst females, and then men, their children, because they are complex and difficult over that. So this is coverage of reaching out to people who are requiring antiretroviral drugs. These are just the number of new infections due to mother-to-child transmission. And I think the key component is that from 2004, as you can see, declined from above 25% to now around 7%, which is around 2023. And you see that it is because of antiretroviral drugs given, which we scored the option B+. So as of 2023, 6.7% was the final transmission rate after breastfeeding, but the elimination of mother-to-child transmission target is 5%. So we are still short of 1.7%. So we still have to work hard as Malawi to reach into the elimination zone. And this is the equivalent to the deaths, number of new infections amongst children. So if we had not provided antiretroviral drugs, this would have been the number of children with HIV. But because of that, these are the numbers with HIV. So we have this block of children who about 136 new child that were prevented from 2004 to 2023. Excellent progress. And on the Malawi program, as they finalize on the Malawi program, you see that this, we talked about the global 95% targets by 2025. You see that amongst women, the Malawi program, 97%, 96%, 96%, which means the Malawi program, even before 2025, already above 95%. Excellent work for Malawi. For women. For men, it's 93, 95, 95. So the second and third 95s at the dot of mark of 2025, but this was reached in 2023. Accessing HIV testing, we still have to pull up before we reach 2025. Children, we are still struggling, as I said. So 87, 83, and 84. So which means 87% those who are able to tested and known to be positive, 83 started on treatment, and 84 viral suppression. So this is just to mention that we really need to work very well on men, and also especially for children. So as you take a breath and a sip of water and a sip of coffee where you are, now moving on to an example of a program in Malawi, which is in this case the Partners in Hope program. So Partners in Hope actually is a local organization, and it has a medical center, which is the hospital. It is private and also public, which is a mixture. And they do general health care, which has internal medicine, pediatrics, obs and gyne, but also surgery and other accessible ambulatory and inpatient, with a laboratory and diagnostics, robust molecular lab, and X-rays and ultrasound. Then apart from the medical center, we have the program, the public health approach, which is what I'm going to talk more now. The program has the clinical HIV care and treatment, the monitoring and evaluation, and also the implementation science, which is the research program. So in the clinical care, HIV care and treatment program, we have two major grants from PEPFAR through USAID, and one is client-oriented response for HIV epidemic control, which is the HIV care and treatment. Then we have the TB local organization network, which is the TB loan program. So as an example, within this session, I'll use the CALL, which is a 5-year program of 80 million, and we are currently in the 4th year. We support actually HIV care in 9 districts in Malawi, 9 out of 28, 123 health facilities, and we have a collaboration with the Catholic Health Commission program in Malawi, which does orphans and vulnerable children. And then we have also a collaboration with the University of California, Los Angeles. That is why I am here to actually deliver this session, because of that partnership that Partners in Hope has with UCLA. Currently, 207,079 people living with HIV are receiving care and alive currently at within the 9 districts, and this is 29% of the national program. The national program has just above 950,000 people alive on treatment. The 4 objectives of the core program is to look at increasing and sustaining the proportion of people living with HIV identified and linked to treatment. And the second one being to increase durable viral load suppression. And the third one being high impact preventive services, mainly pre-exposure prophylaxis oral, and now we are moving into injectable cabotegravir long-acting exposure prophylaxis. And finally, improving availability of quality site level data. So I thought I should just give you a dashboard, just a few of the some of the indicators that we follow in that case. And for the indicators that we follow in this case, this is what I wanted to mention, that, for example, from October 2023 to August 2024, the number of new HIV infections, we are expecting that by September 30, 2024, we should actually test 819,000. And by August, we had already tested 925,000. So, which means that this is 113% of what was expected, because by August, we were supposed to only cover 92% because it was 11 months. For number of new HIV positives identified, we're supposed to get 12,565, but we were already able to get 13,046. This is like a 4% above our expected target of 92% by actually August 2024. When you look at the number of new people living with HIV identified and started on antiretroviral drugs, we were expected to start 11, close to 12, actually 1,000, but we were able to start 13,000 on antiretroviral drugs, which is 11% above our expected target. When you look at now people living with HIV overall, as I mentioned, we have 207,000 out of the 211,000 expected. This is 98%, and it's pretty much a good accurate progress towards that. Pre-exposure prophylaxis new cases, we expected to have 15,000. We're able to actually get about 18,652, 21% above our expected target. And the number of women who were living with HIV and screened for cervical cancer, because as you know, cervical cancer is a high risk for HIV positive women. So we, instead of screening 36,500, we're able to screen over 44,000, which is 21% above what we expected. So overall, as you can see, the core program of Partners in Hope under PEPFAR USAID, it is doing extremely well in order to contribute the work of the national response for Malawi. Now, after talking about HIV, I thought now we go into integrating, knowing that when people stay longer, you know that then they are going to be having diseases of people who stay longer of the age above 50, but also those who are well. These are hypertension, diabetes, mental health, cervical cancer screening. So the cervical cancer, these are the conditions that will be available. So now we are talking about integrating non-communicable diseases in routine HIV care. After we had already integrated, for example, TB HIV, and also integrated sexually transmitted infection conventional treatment. So I'll just take you through a couple of examples of the initiatives that we've done. So non-infectious diseases have emerged as a leading cause of death among older HIV positive individuals. It is important that the important risk factors for cardiovascular disease are obesity, smoking, hypertension, diabetes, and dyslipidemia. So HIV infection itself may also cause inflammatory activation in the blood, leading to accelerated vessel aging and increased arteriosclerosis. So that's why we're trying to avoid cardiovascular diseases by making sure that we manage non-communicable diseases amongst HIV positive people. National efforts for integrated HIV NCD care in Malawi, integrated cervical cancer and HIV screening was actually instituted in 2007. In 2015, HIV and hypertension integration efforts were started by as a thematic area under the Ministry of Health. Later on, in 2016, the National Policy on Hypertension Screening was included in the ART clinics. So then, scalable integration models have gone throughout the facilities. They are more robust in the partner-supported districts. So just to mention that the success of HIV programs with millions of people living with HIV now longer globally, it is actually, it undercuts that by escalating burden of non-communicable diseases. So people, instead of HIV, dying of HIV, they are now dying with non-communicable diseases. So in sub-Saharan Africa, we still have a dual burden of HIV higher and also growing chronic disease burden. And therefore, I just wanted to mention that we are asking you a question, why should we integrate HIV and NCD service delivery efforts? So the potential impact is that the enhancement of HIV and NCD service delivery can not only help people living with HIV to live longer, healthier lives, but can also leverage resources whereby non-infected people can benefit from the resources that are available within HIV programming. Just an example, my previous job at the Lighthouse, we actually integrated in 2015, integrated care and holistic treatment was the initial concept of Lighthouse as it grew from its palliative care. So proper screening for non-communicable diseases was started in 2015, whereby all patients were having weight and height, which means calculating a body mass index, blood pressure, and a reminder of annual cervical cancer screening on site. All required medical products for hypertension, diabetes, epilepsy available at the Lighthouse as a one-stop shop. When you looked at the data in 2015, we saw that out of the 3,448 persons diagnosed with hypertension, 53% were male and 46% were in the ages of 40 to 49 years of age. And the prevalence of hypertension was about 16% in males, almost twice as high as in females, which was 9%. Of persons on pharmacological treatments for 6 months, 38% were controlled for blood pressure for the mild ones, while 30% for moderate ones and 21% for severe cases. So all just to mention in this case overall, which means that we had like an overall 26% of blood pressure control, where when you checked on a follow-up, you were able to see that blood pressure was normal compared to the previous visit. We were worried that if we give people antiretroviral drugs and also antihypertensives, probably adherence of ART would be poor, but ART adherence for hypertension patients receiving hypertension medication was comparable with patients with non-hypertension medication. So 80% versus 79% respectively, which was good at that point in time. Costs, it was discovered that antihypertensives were not really expensive. So approximately 14,000 US dollars, and that's about $4 per patient per month, you'll be able to manage all these cases. We also did a study just to look at comparison of prevalence of high blood pressure and prevalence of hypertension. So the prevalence of hypertension was lower in the cohort compared to the national program estimates. So the blue is the estimates, but this one actually, I have to be clear, it was one blood pressure measurement. So it was high blood pressure, while the light blue is actually two consecutive measurements on 2 consecutive days. So this is actually the actual hypertension in that case. So we're able to see this, where you see that a single raised blood pressure is not the same as hypertension. At least 2 measurements on at least 2 occasions would change a picture from what you've seen, the blue, and also here, the yellow in that component. So the blue is the national, while the yellow is actually the component of the cohort at the Lighthouse. So this is just one of the paper which looked at the 24-hour ambulatory blood pressure monitoring as we're managing. So you can look at the paper and see how it comes. It's published in the Global Heart. And then one of our one of our partners in health, these are our colleagues in the southern part. Very, very influential long-term HIV global health expert, and he was able to do the study in one of the districts, and they had the HIV platform leveraged to offer integrated primary patient care, and amongst NCD clients, 15% were HIV positive. It is feasible with considerable investments to and training to manage both the primary care and also HIV and primary care non-communicable diseases. And also there was a utilization of regular mass screening, everyone to be screened for within the OPD, and 58% was screened for hypertension, and 9% were referred to care, 29% for diabetes, and 3% referred for care, and experience was that you can be able to manage diabetes and hypertension. So integrated chronic care clinics were decentralized to 15 primary care clinics, and in a retrospective cohort study, it was demonstrated that there were good outcomes. 1 year retention at 85% for HIV and 72% for non-communicable diseases, with an improved viral load of 85%. So you can see HIV and the non-communicable disease treatment adherence is equivalent to what the Lighthouse was showing. Coming home to Partners in Hope. So actually, this is a paper that Dr. Lisa Hoffman from UCLA led, which is high rates of uncontrollable blood pressure in Malawi, adults and living with HIV and hypertension. So the objective of this study was to characterize actually rates and factors associated with blood pressure. So we did a prospective observational cohort in the HIV clinic, where we looked at controlled hypertension, systolic of 140, above 140 and above 90, then controlled hypertension being less than 140 or less than 90, systolic and diastolic respectively, and then antihypertensive non-adherence score, self-report of missed doses at each visit, looking at the higher score versus the worst adherence. So results out of the 158 participants, 23% were on hypertensive medication, and we saw that the median time on antiretroviral drugs was about 7 years. 19% achieved blood pressure control over the year of follow-up, so equivalent to the 26% also you remember that we saw at the Lighthouse. Self-reported non-adherence to hypertension medications was the only factor significantly associated with uncontrolled blood pressure, because actually some of them had challenges to get the medication. So the average non-adherence score for those with controlled blood pressure was about 0.22. So conclusion for this study was that adults living with HIV and hypertension had low rates of blood pressure control over 1 year associated with self-reported non-adherence to antihypertensive medications. Interventions to improve blood pressure control are needed to prevent associated long-term cardio and cerebrovascular morbidity and mortality. And currently, Dr. Lisa Hoffman is leading the team, collaborating UCLA and Partners in Hope to put up actually a robust hypertension as trial, and already a pilot was done. We'll be putting in also a grant to NIH to really explore more on this. And finally, just to mention that there was another study where our colleagues in Zomba, one of the districts, where they looked at HIV patients who were screened for hypertension, and 765 were diagnosed with hypertension, and the hypertension prevalence was about 13%. And of the patients with complete blood pressure information available, we saw that the 43% were in stage 1, 34% in stage 2, and 22% were in stage 3. So 25 diagnosed with diabetic mellitus, and the prevalence of diabetes was 0.8. So prevalence of hypertension and diabetes mellitus were similar as in comprehensive SARS at a baseline clinic. So combined prevalence of hypertension requiring drug treatment and diabetes mellitus was about 14%. So the lessons that we learned from there was that benefit of thorough preparation and the routine workload, waiting time initially increased, stockouts and co-dispensing on SD drugs was challenging, also monitoring and evaluation papers versus actually the components of electronic medical record system, you may have some errors. So glucose screening every 2 years was combined with viral load testing later on. So in summary, for HIV and NCD's integration, the final thought is that tension between differentiated care models, because you are providing 6 months. So for antiretroviral drugs, you can provide up to 6 month dispensing for antiretroviral drugs for 6 months period, while for the antihypertensives, challenges of availability of the drugs may not allow for you to provide for 6 months. Availability of blood pressure measuring devices, these usually break down, batteries having a problem. Usefulness of screening for other diseases, for example, diabetes, hyperlipidemia, is clearly only useful with access to adequate treatment. However, there's that leveraging the successful HIV clinic structures with substantial medical funding for other chronic diseases can be used for HIV and NCDs. And normalization of HIV as a chronic disease when you combine them with the possible reduction of stigma. So then we looked at the global component of HIV, the global burden and progress for HIV, the burden of HIV and progress in Malawi. We've looked at the HIV and non-communicable diseases, and knowing that you can manage the HIV program with non-communicable diseases together and have efficiencies. So my 1 minute is just to say that the partnership that we have, I really enjoy it because currently I have like a partnership of an implementing partner in Malawi where I am able to collaborate with the University of California, Los Angeles, University of North Carolina in Chapel Hill, and also University of Washington in Seattle. So here you can see that I have some work which I do with UNC, and also have some work which I do with UW. But my major work now, which is significant, is the work which I am doing with UCLA, because currently Partners in Hope has a direct relationship with UCLA. So working together with Dr. Lisa Hoffman, and also we've extended the partnership to New York University because Dr. Corina Mucharad has moved to New York University. So that's another collaboration PIH is talking. Currently, we have a cancer program of human papilloma virus vaccine that we have a grant from National Cancer Institute of the NIH that both Corina and Risa and myself are co-PIs. So with that, I would like to say, Karen, thank you for listening. It's a lot of material. I will share the slide deck for you to look into it in detail. Otherwise, back to you for any observations. Thank you for listening.
Thank you so much for that, Professor Phiri. That was a really, really insightful presentation. And so I think we'll transition now into questions because I'm sure we have many of them. But I can kick things off for us, and then I can perhaps call on other people who have questions. I think one thing that really struck me from your presentation, Dr. Phiri, was the data from Partners in Hope. And so I'm curious, what do you think are some of the factors that have contributed to Partners in Hope's success in Malawi, especially in regards to exceeding your target? Since you said, for example, you were 11% above your target for people who were able to receive antiretroviral treatment.
So thanks for that, actually. So the drivers to the success is that the Partners in Hope is an established organization. The structure which is available starts from the leadership, and then we have program managers who are at the central level, and then we have program officers and coordinators who are in the districts. Then we have the facility staff who are in the 123 sites. So one is the training that we provide to our providers, two, supervision. Then we have incorporated the continuous quality improvements projects within the facilities. Then every month we do data reviews where we review the data for the previous month and then see where we are doing well and what are the drivers of why we are doing well, where we are not doing well, what are the key contributing factors why we are not doing well. Then we look at what are the mitigating factors that we can do for us to do well. So that component with the program structure like that, and then in the capacity building and the partnership that we have, Partners in Hope and UCLA, then we have the research, which we do rapid assessments, which would tell us where we need to pay more attention. Then that works out quite well. And the resources that we get from PEPFAR, from USAID, we have much as there's not too much money, but what we have, we are able to use efficiently, and it makes us easier to do our programs because we have what we need in terms of resources. Thank you.
Thank you. That makes a lot of sense. Kind of related to that, I know you mentioned UCLA in your presentation and just now, and so I think we are all very interested perhaps in hearing more about UCLA's role specifically, and what does that partnership really look like?
So thank you. So currently the setup is that with the, for example, the client-oriented response on epidemic control, the core. So the partnership dates back to 2009. And so been getting together, and previously UCLA was a prime. And in this case, we have Partners in Hope as a prime, and then there's a sub-award which is given to UCLA. The role of UCLA, one, is to provide the capacity building, which means it's training. It's not only into the program, also in the medical center. There are actually residents and students who come in into Partners in Hope to rotate through the medical center. And then apart from the capacity building medical training, there's research. So the research component is led significantly, in this case by the UCL team, whereby we have like a principal investigator. So in this case, like Dr. Risa Hoffman, Dr. Kathy Dovel, and in this case, you have Dr. Corina Mucharad, and then the rest of the team, Tom Coates and others at UCLA. So there's a component of research in there. So the capacity building is not only a program implementation, but also in research development. And so as a team, we work together and conduct robust research. And it is a bi-directional relationship and benefit. In this case, Partners in Hope benefits quite a lot from the expertise and the experience from UCLA. UCLA has a platform where they can also put a collaboration and partnership in order to deliver their skills either in clinical or in training or in public health. That's how it looks like. Thank you.
Thank you so much. I wanted to open the floor to anybody else who had some questions. Feel free to unmute your mic.
I have a question. Hi, Professor.
Yes,
Phiri.
Yes, please.
Thank you very much for taking the time out of your busy schedule to be with us today and for this very wonderful presentation. My question is on one of your initial slides. It was a pie chart, and you distinguished between Eastern and Southern Africa and then Western and Central Africa. I think most of us, when we think about HIV incidence and prevalence in Sub-Saharan Africa, we kind of put most of the like non-Northern African countries together. And so I was wondering, is there like an epidemiological or perhaps maybe like a historical reasoning for why you did that, like you created those two categories?
So thank you very much. That's actually a good question. So usually you have East and Southern Africa, then you have the West Africa over that. So the North Africa, it is considered that when you look at the burden of HIV, the Northern Africa actually mimics more with the Middle East in that component. So, and then you see that when you look at the burden epidemiologically between West and North Africa, although we think that because they are the West and the North Africa, you know, the burden is lower compared to the East and Southern Africa. And so although we know that West and North Africa, where the burden is lower, but it is clear that when you look at the Western Africa, you should be able to zoom in significant. It is for purposes of how can we put our programs that can focus within the West Africa, which is mainly Francophone, and then how would be able to manage programs within North Africa. But as I said, the North Africa approach is usually actually approaching programming with the Middle East. Thank
Thank you
you.
very much. Yeah. I have a second question if anyone has a
Sure.
question.
Sure.
Okay. My second question has to do with the number of children who know their status and are receiving treatment. I think typically children tend to be closer to their mothers. And so for me, I was expecting a little bit more like closer numbers between the number of children that know and are receiving treatment and the number of women that know they have HIV and are also receiving treatment. But there was a sharp contrast. And so I was wondering, like, what do you think might be driving that? Because like the women are higher, but the children are lower. And so I was just curious if you had any thoughts about that.
Thank you. So I realized that when you come in, I'm told that there are students who have initial and prior interest in global health. I realize your questioning is beyond interest. You are really teasing out, why is it like that? So in this case, what I would tell is that that's what we thought too, because usually are diagnosed because of the child. So the child is sick and time and again, so then you're saying, okay, hang on, let's test the mother. And you see that the mother is positive. What we thought was that indeed when they're coming in, they would be able to, even when they're on treatment, they would be able to come. But you see that there's a component of structure from the community, from the individuals. There's a component from the service providers in the facilities too. So for testing, because we are using early infant diagnosis, because you have to use PCR for below 12 months, and then so the testing for that, it means the ones who are coming in after delivery, they come in for a checkup at 7 days, then they're supposed to come back at 6 weeks post-delivery, or 6 to 8 weeks to test for the first test. Usually, what happens is that the mothers are not coming back for that check. So guess what? If they have been started on treatment, they would come to the facility to pick up their medication, leave the child at home. So that's why I said there's a contribution from the service providers, because they should be able to know if it is labeled PMTC, they should say, where is the child? And then one would say either the child died or the child is at home. So in terms of programming, there's an emphasis in the training to say that, please, if a woman comes in, talk about children in that case, but you would think it is obvious that they would be coming with a child. Even when they've been started on treatment, you see that a mother would come and pick up the medication and not pick for the child. So now we started with a program where we talk about mother-infant pairs. So we take the card for the mother and the card for the child, put into one file. So that when the mother comes, the provider will say, hang on, where is the child? Thank you.
That's very good. I'm glad that people are thinking about it and doing that. Thank you for sharing that with us.
You're welcome.
If we have time, I have one last question. Hi, Doctor. Thank you so much for, I want to emphasize that thank you for giving us this talk. My question was that, so there was like a little bit of like way to go for it to meet that 2025 targets in terms of like people who know they have HIV, in terms of like people who are receiving ART therapies. And so I wanted to ask, in the next year that we have, what do you think are some high priority areas for intervention, to kind of target, to make sure that we're on track to get that, if as much as possible, especially within like small communities within these countries that have higher prevalence?
Thank you. That's a good question. As I said, indeed, going deep into public health in that case. So, because you are thinking like, hang on, it's only just in the coming 12 months, then what are we going to do? So for HIV testing, we are looking at what we say the last mile. So where are the people more who do not know their status? And these are amongst the men, and these are amongst the children. So it's really to provide targeted interventions, especially for men, to ask a question: where do men congregate? And so either if they congregate into pubs, then we do moonlight testing programs, whereby vans go out in these people, whereby they look at either sex workers and their partners, but also in other places, they are not sex workers. Others are not men who have sex with men. These are actually people who are just in pubs, and so you just make sure that to look at, because in other countries like in Sub-Saharan Africa, being married is a higher risk for HIV infection compared to if you are getting to a sex worker. So in that case, it's because the issue is that people think that if someone is married, it means they're in a stable relationship, so they would be safe. So they're less likely to use protective measures if they would like to have actually intermarital. So in this case, what I would mention is that targeted interventions into men, and then making sure you are running up for 0 to 19. We're doing ramping up of testing for 0 to 19 to make sure that we get as many as we can, because this is where a lot of children are lying into. And then when they started on treatment, there are programs whereby welcome back, what we call welcome back packages. When people have started treatment, have dropped off, we do programs whereby we follow them up, default tracing back to care, bring them into care so that they should stay, and provide messages of adherence so that they should have a proper viral suppression. So these are the initiatives that are put into place to do the last mile. We hope we can be able to reach 95 and also eliminate AIDS by 2030, and just keep the ones who are available now to live longer. Thank you.
Thank you so much.
Thank you so much, Dr. Phiri. I know some students are hopping off for another class, but wanted to say once again, thank you for your time. I'm sure if anyone has questions, they'll definitely reach out in the future.
You're welcome. It was a pleasure, actually, this time.
It was our
very
privilege
much.
to have you here, so thank you.
Thank you. Thank you.
Awesome. Thank you, everybody. Thank you, Dr. Phiri. We will make sure to share your slides with the students, and we will be in touch.
Thank you. Thanks, Elizabeth.
Awesome.
And I'll share the slides so that we can
Thanks,
share with
Dr.
the
Phiri.
team.
Have a good day. Have a good evening.
Thank you.
Thank you, Jenna. Thank you.
Thanks. Bye-bye.
Bye.
Thank you.